First sessions given in the program says, Dr. Bellani. Dr. Bellani cannot be here, but we have, in substitution of Dr. Bellani, Giuseppe Foti. I know Giuseppe Foti for many, many years, and Giuseppe, he is a really expert on that topic, which is it possible to adjust the PEEP level based on electrical tomography impedance? This is a clearly topic of the future that Giuseppe, will speak. The second talk, it's given by Paolo Pelossi. Paolo Pelossi, I know also Paolo for many, many years. We have had many, many discussions, and both Giuseppe and Paolo, their interest is to improve the performance of mechanical ventilation. And in this second topic, Paolo will speak about, the driving pressure. The driving pressure, which is in fact the pressure across the lungs when we are giving mechanical ventilation. And now we know that this is a key aspect about controlling mechanical ventilation. The important thing of that is that in all ventilators in the world, in any ICU, low-income country or medium or high-income country, clinicians, intensivists, or professionals there, they can measure, in that case, the driving pressure. So understanding these together with the electrical impedance tomography will be crucial, to provide, much better treatment to these, patients receiving mechanical ventilation. And finally, it is important to know why, despite an excellent research around the world on how mechanical ventilation should be applied, and now we know excellent guidelines or protocols about how to set tidal volume and PEEP at the bedside, still, there are, people that do not follow that rules, and this is important to recognize and to teach again that when we don't know what happened, we must stay inside the frame of the evidence. This is in fact crucial. And then finally, together with me, questions, and this will be given by Bruno Pinheiro, in that case in Brazil. I met Bruno, several years ago, and Bruno will be an excellent speaker and professional to tell this. And finally, for the questions and answers, we have Fernando Rios in Argentina and Leopoldo Ferrer in Colombia that together with me, we will follow the session and ask questions to the different speakers. So
very much. It's a great honor to give this presentation in this very new, exciting format for exchanging and share scientific research and clinical knowledge. So thank you again. So my talk will focus on driving pressure and how this can be really the new polar star in the mechanical ventilation setting. I have no conflict of interest for this specific lecture. So first of all, just remind to all of you the basics for ventilator-induced lung injury. The main parameters which promote ventilator-induced lung injury are the following: the tidal volume, and of course, as a consequence, the plateau pressure of the respiratory system and the level of PEEP. Of course, the difference between plateau pressure and PEEP, which we will discuss, the driving pressure, may play also a role. Other factors have to be also considered, and I will mention in my talk. So also the role of the respiratory rate and the inspiratory flow, which interact with the driving pressure according to the possible role of energy and power. And all these factors have to be considered to induce ventilator-induced lung injury. The three main mechanisms which has been supposed and proposed to play a major role to induce ventilator-induced lung injury are the high pressures, so the so-called barotrauma induced by high tidal volume or high plateau pressure, volutrauma, so high increase in volume, which may be induced by high level of PEEP or high tidal volume, and the cycling opening and closing of the alveolar units during mechanical ventilation, which may induce atelectasis trauma and eventually biotrauma. So what is the driving pressure? Here is presented the graph of the inspiratory flow, of the volume and the airway pressure during controlled mechanical ventilation in volume control. So the plateau pressure is the pressure at the end of inspiration during an occlusion, and the pressure at end expiration is the pressure at expiratory occlusion, which may be or the PEEP by itself or the presence of an auto-PEEP. The driving pressure during controlled mechanical ventilation is defined as the difference between the plateau pressure and the pressure at end expiration. In presence of auto-PEEP, the auto-PEEP. In other terms, the driving pressure is the difference between plateau pressure and PEEP, which can be written like tidal volume divided the compliance of the respiratory system. In other terms, since the compliance of the respiratory system is associated with the amount of the end respiratory volume or the amount of aerated volume, the driving pressure is an easy parameter to be obtained at the bedside, which gives us the information of the ratio between the tidal volume and the aerated lung of the lung. In other terms, give us information about the strain of the lung. So driving pressure is the tidal volume corrected for the baby lung or end external lung volume size. This is a clear example. This is a lung with a minor amount of atelectasis and a large amount of aeration at expiration and inspiration during a ventilation of 500 milliliter. Compliance is 50 milliliter per centiliter of water, and the driving pressure in this case is 10 centiliter of water. Imagine that we have another lung with a higher amount of densities and pathology and a lower amount of aeration, and we give the same amount of tidal volume. In this case, the compliance of the respiratory system is alpha 25, so the driving pressure for the same tidal volume is double at 20 centimeters of water. This means that the same amount of tidal volume in this new lung, less aerated lung, the amount of stress, of strain is much higher. So, if we want to reduce the driving pressure and to keep the tidal volume within the amount of volume at end expiration, we have to reduce the tidal volume, in this case at 250 milliliters. So the driving pressure is a very good parameter which gives us the information at the bedside if the tidal volume that we are delivering to the lung is too high as standardized to the amount of aeration of the lung. Which is the clinical evidence. In surgical patients, we have found in a large number of patients and studies that there is a relationship between the driving pressure and the during surgery and the probability to develop postoperative pulmonary complication. We also found that there is a threshold. So when driving pressure during anesthesia is higher than 13 centimeters of water, there is a much greater increase to develop pulmonary complication. And this has also been shown in an observational trial in a large number of patients. As you can see, the limit is around 13 centimeters of water, at which the increase in the development of postoperative pulmonary complication is higher than when the driving pressure is lower than 13. And of course, at the decreased amount of driving pressure, there is a progressive increase to develop postoperative complication. So, driving pressure during surgery should be always maintained at less than 13 centimeters of water. Another applicability of driving pressure, even during surgery, is to optimize the setting of PEEP. This is again an example in which we are delivering the tidal volume in a less aerated lung, and we have a driving pressure of 20 centimeters of water. Then we increase the PEEP, for example, and we increase the amount of aeration. And for the same tidal volume, the driving pressure is decreasing, so the compliance of the respiratory system is improving. Finally, if we increase too much the PEEP, delivering the same amount of tidal volume, we have again an increase in driving pressure. So, one hypothesis is that we can set the PEEP according to the best driving pressure. On the other side, to avoid PEEP high enough to increase the driving pressure. This is what exactly we found in our studies in surgical patients. As you can see here, this is the risk to develop pulmonary complication in patients treated with relatively low PEEP during surgery. When PEEP was applied and driving pressure decreased, there was no significant improvement in the outcome of this patient in terms of observed pulmonary complication. And the same when driving pressure did not change. However, when PEEP applied was associated with an increase in the driving pressure, we observed a major increase in the risk 3 times more to develop post-operative pulmonary complication. So this changed the paradigm of use of driving pressure, not according to the best driving pressure, but to avoid to increase the driving pressure to optimize the PEEP level. And this is exactly what we are studying right now in a large randomized trial, in which we are comparing low PEEP level during surgery and the highest PEEP level to avoid an increase in driving pressure, and looking at the proportion of PPC after surgery. Do we take attention about driving pressure during surgery? Not too much. As shown in this study, in which we collected data in more than 8,000 patients all over Europe, we found that even more than 50% of the patients during surgery have driving pressure higher than 13 centimeters of water. What about non-RDS patients? We found in a large collection of patients without RDS admitted to intensive care and mechanically ventilated, the driving pressure was associated with the risk of mortality in hospital, and especially when driving pressure was higher than 13 centimeters of water. We recently conducted a large trial comparing in non-RDS patients low tidal volume, so the patients were ventilated with 4 to 6 liters per kilogram predicted body weight, with intermediate tidal volume from 8 to 10 milliliters per kilogram predicted body weight. And we look at the possible effect on ventilator-free days. The study that has been recently published on JAMA compared these two groups, tidal volume was 6 or 9 in non-RDS patients, and driving pressure was 11 versus 13, and we found no difference in ventilator-free days or other major endpoints of the study, suggesting that within 13 centimeters of water driving pressure, there is no negative effects on the lung. Further, we found that, however, patients treated with progressive low tidal volume, they had a higher frequency in hypercapnia and longer mechanical ventilation days with provided. And there were even no difference between these two tidal volume and these two driving pressure when we subanalyzed the group with PO2 lower than 200. So even in non-RDS patients, we believe that driving pressure is a possible parameter to be considered and should be maintained at least, again, less or equal than 13 centimeters of water. Again, as during surgery, when we look at the mechanical ventilation setting in non-RDS patients, we found that almost 30 to 40% of the patients are ventilated with a driving pressure higher than 13 centimeters of water. What about driving pressure in RDS? This is the classical study from Marcelo Amato showing that driving pressure was associated with the risk of death in the hospital, and especially when driving pressure was higher than 13 centimeters of water. Again, this number is equal, seems to be equal and similar in different categories of patients. In fact, for example, the odds for barotrauma across the different quantiles of driving pressure shows that when driving pressure is higher than 13, there is a major increase in barotrauma and eventually risking mortality. case for tidal volume. And this is clearly explained, as discussed before, because the driving pressure gives us more information about the ratio between the tidal volume and the related lag, which is the strain. However, if we consider the driving pressure to set the optimal PEEP, the data are not so straightforward. This is a very recent study from the Brazilian group, in which one group of patients with severe RDS was ventilated with relatively low level of PEEP, 12, according to the low PO2 FO2 NIH table, and the other group was treated setting the PEEP according to the best driving pressure and best compliance associated with lung recruitment maneuver. The difference in driving pressure, as you can see here, was almost nothing in the low PEEP group, while 2-3 centimeters of water in the titrated group. This slide indicated that this group of patients was not natural. And anyway, this study showed higher mortality in the group in which PEEP was set according to the driving pressure. So again, similar to the study in anesthesia and surgery, as I showed you before, driving pressure seems to be more effective to set the optimal tidal volume and not to set the optimal PEEP. What about ECMO? We found in a large series of patients that driving pressure was the only parameter of the mechanical ventilator associated with mortality during or full ECMO or echo to R. So again, this parameter seems to be very important when we are setting the tidal volume in this clinical condition. I want to conclude my talk relating the driving pressure to the concept of energy and power and trauma. In fact, the energy is given by the multiplication of the airway pressure and tidal volume, which means the elastic storage of energy, the airway resistive losses, the acceleration of air masses, the parenchymal losses, thus lung hysteresis and ventilator-induced lung injury. So, as we have seen, driving pressure is the ratio between tidal volume and compliance. So, the energy is related to the driving pressure, and even more to the square of driving pressure. So, we can also consider that from the energy, we can go to the concept to the mechanical power, which is related to the energy according to the time of application, the respiratory rate. We have recently shown in a large population of patients, more than 8,000 patients mechanical ventilated, as you can see here, with different models. I don't want to enter here into detail, but as you can see from this graph, that higher mechanical power, so the driving pressure and the respiratory rate combined, was the single parameter associated with mortality in a large population of mechanical ventilated critical patients. We also look at the different quantiles of mechanical power and the risk of hospital death. And we found that a threshold of 17 joule per minute was associated with an increase in the risk of hospital mortality. So driving pressure may be associated to the concept of energy and power in these patients. Overall, we believe that especially in RDS patients, but also in the other conditions, in non-RDS patients or during surgery, we should not use excessive level of pressure within the lung, and especially excessive level of PEEP, unless absolutely necessary. In fact, PEEP may induce static strain and area of overinflation, here shown as blue area. So it is possible that we should ventilate our patient with relatively low tidal volume, low plateau pressure, a moderate to low level of PEEP with low driving pressure and a relatively low respiratory rate when possible, in order to minimize the possible injurious effect of energy and power. So the limitation of the driving pressure are mainly two. The first is the role of the chest wall. In fact, as shown in this slide, when we have a major effect of the chest wall, the real driving pressure, which is calculated from the plateau of the respiratory system, may not be the really driving pressure inflating the lung. In fact, you see these two different cases in which we have the same plateau pressure, the same PEEP, the same driving pressure. Since the chest wall is much stiffer in this condition, the driving pressure of the lung, so the transpulmonary driving pressure, is much lower in this case than in this case, even if the driving pressure of the respiratory system is the same. So, in case of severe alteration of the chest wall mechanics, driving pressure may be altered, even if our data suggests that overall the measurement is quite sensitive enough. The other limitation, possible limitation, is the effect during assisted ventilation. This is a presentation of the flow and airway pressure curve during pressure support. And you expect that the driving pressure is different between peak pressure support and the pressure at the end expiration. Really, the patient is making an inspiratory effort, as shown here. So, the driving pressure of the airways is not equivalent to the real driving pressure of the patient, which is the difference of the peak pressure of the airways and the swing of the esophageal pressure. So, it is possible to measure the driving pressure during pressure support or other assisted ventilation. This is a study that we performed years ago with Professor Foti, which is a co-speaker in this session, and showing that if you include the airways at end inspiration, you can reach a plateau pressure in the airways, and then you can estimate in different conditions the possible real driving pressure or of the patient, even during assisted ventilation. So, in conclusion, driving pressure may influence the plateau pressure of the respiratory system, may represent the strain of the lung, which is a very important parameter, as I showed you before, to mainly set the tidal volume, but can be also connected with the power, since the energy is depending on the square of the driving pressure. The power is the energy related to the time, and also in the future to relate the power to the area of aerated lung, which means the intensity on the lung. So, in conclusion, the driving pressure is the tidal volume corrected for the baby lung size, so the amount of the aerated lung. So that is very important to set the tidal volume. And in fact, is a strong pathophysiological rationale to better tailor the tidal volume instead to use the tidal volume per se according to the predicted body weight. There are evidence for retrospective, randomized, and observational studies that in non-RDS patients, during surgery in ICU, in RDS patients, and even during ECMO, a threshold of 13 centimeters of water should be considered when we optimize maximum level, when we optimize mechanical ventilation. Driving pressure, when increased with the application of PEEP, is associated with worse outcome. So it's a very important parameter when increased with PEEP. When there are less evidence, it can be really helpful to optimize PEEP according to the minimal driving pressure. I showed you the mechanical power, which depends on the driving pressure, on the square of the driving pressure, is associated with mortality. It may be a very interesting parameter in the next future to optimize the setting of mechanical ventilation. So driving pressure and the respiratory rate together in this calculation. There are possible limitations, so the altered chest wall mechanics or assisted spontaneous breathing, but I showed you that, or if you partition the respiratory mechanics or you use end-inspiratory occlusion, you can have some additional measurements of driving pressure even during assisted ventilation, so it's not a real limitation. And of course, we need further experimental and clinical research to better identify the role of driving pressure in these different clinical conditions. Thank you so much.
Thank you very much, Paolo, for this very nice lecture. Now it's time to Giuseppe. Are you ready, or let's...
Okay. Hello to everybody. Okay, my topics is about the use of EIT, electrical impedance tomography, as a tool to adjust the PEEP level. Next, please. Those are my conflict of interest. And the dragger one may be relevant, since the machine that we use is the Pulmovista. The next one. All right. Here, maybe if you can start the movie on this slide, please. Otherwise, is just to give you an idea what is the pulmovista, or the electrical impedance tomography. There is a belt around the chest wall, and as you can see, can you start the movie? No. No, okay, go back. Okay, that's all right. You see changes in impedance, meaning that this is air going inside into the lung. You can measure, obviously, tidal volume, but what is most important, you can see on the right, beside the total tidal volume, you can select zone on the lung and see the amount of air that goes in every zone of the lung. In this case, you can see, for example, that 38 in one side, 38 in the other one, 7 and 70. This is a kind of interesting information that we should keep in mind. Remember, homogeneous distribution of tidal volume is ideally a goal. Instead, inhomogeneous ventilation means that there are areas that gets more volume than others. Next. Right, in this, I think you can go to the next one. Please go to the, perfect. On the upper part of the slide, there is a distribution of tidal volume. On the upper part, you can PEEP level according to the NIH protocol. On the lower part of the slide, after open lung approach, so using a higher level of PEEP and promoting alveolar recruitment. You could see that with the impedance, electrical impedance tomography, the distribution of the tidal volume that is the same in both the picture is more homogeneous in the lower part of the figure when you open the lung. Instead, in the upper part of the figure is more dishomogeneous. The next one. Now we have to go to the concept of how to select the PEEP. This is a very difficult issue, and certainly I will go into the issue, but not too much in details, otherwise we'll start a discussion that will never stop, not even tomorrow. Let's go back to the basic call of lung recruitment. On this old slide, but very, very important one, you see on the blue line, patient with the ARDS, the distribution of the opening pressure of those patients. On average, around 20 centimeters of water, but many parts of the lung can open at 35, 40, and 50. On the red side, on the red represent closing pressure. It is lower. This is the pressure at which the lung closed. So this is the rationale to promote a recruitment maneuver to open up the lung and then select the PEEP level to keep the lung open. The next one. I imagine many of you use this technique to select the PEEP in ARDS patient. At least this is the one that I use mostly. This is on the y-axis. There is oxygen saturation, and those are patients that do respond in terms of oxygenation to recruitment maneuver. Please push the button, animate the slide. Could you please the next one? Okay, stop. You see this patient here, let's call it the yellow guy. He has a saturation about 88, following a recruitment maneuver goes to 93. And and then goes back to 88. It means this lung can be opened, but do not stay open with 7 of PEEP. So we do repeat the maneuver, we increase the PEEP to 10, and then finally we maintain the recruitment. This is the technique of the sustained lung inflation. It is a kind of different from an open lung approach that you know and that is very famous in the art trial. Please, another click on the slide. Let's call this green, like the Italian composer. Okay, Mr. Green opens up very well the lung, going from 88 to 97. But with 10 of PEEP, we have de-recruitment. We have de-recruitment even with 12. And finally, we stabilize the lung with 15 of PEEP. Okay, that's the usual way we do it in clinical practice. Next slide, please. Now, what can we do with electrical impedance tomography? Unfortunately, I can't use the mouse, but I think you understand what is going to happen here. You have a patient in which we apply a recruitment maneuver, a single inflation 40 by 20 seconds. You could easily understand that the lung is recruitable, because then following the maneuver we go back to the initial peak. The difference in end expiratory lung volume is alveolar recruitment. I do repeat, is alveolar recruitment. But also you see that during time, this alveolar recruitment gets lost, and the lung volume in a short while, 15 to 20 minutes, goes back to the initial value. So I have an important information from this slide. Lung is recruitable, but the PEEP is not enough, can't stay open. So we do repeat the maneuver, and we increase the PEEP of 2 centimeters of water. Thanks a lot if you move the mouse, I really appreciate. Anyway, and then we stabilize the alveolar recruitment. Next slide, please. If you do just an adjustment of PEEP without changing the PEEP level, you cannot say that the changes in end expiratory lung volume correspond to alveolar recruitment. This is something that we have to clearly keep in our mind. Please click. This is a change in end expiratory lung volume measured by electrical impedance tomography by a change of PEEP of 2 centimeters. Click. Is made of 2 components, recruitment and the click, alveolar distension. We could evaluate this difference. Please go to the next slide. If we compute the amount of volume that is alveolar distension, meaning alveolar compliance times the level of PEEP applied, please click. You can see that in this case, below the red line is the volume that increases just because of inflation of the end expiratory lung volume at the basal PEEP. And the green one is the new alveolar recruitment, but it is not the same in all the patients. Next slide. So we evaluate if we could use EIT to select the PEEP level, and most importantly, if there is results that we get are different from the result that we get using standard method as compliance measurement, driving pressure if you want, or oxygenation. Next one. This is the study layout. First, PEEP level was established according to NIH PEEP FIO2 table, okay? And then we started with the recruitment maneuver and adjustment of the PEEP level in order to stabilize the recruitment. The last step was the ideal PEEP level plus 2 centimeters of water. So in the blue part, we did a recruitment maneuver, see if there was a recruitment, and adjusting the PEEP in order to keep steady the recruitment. Next one. This is an example. At the beginning of the panel A, you see the RDS network PEEP adjustment. Then the recruitment maneuver, the larger recruitment in this case, the first was not stabilized. On the third level step, there was a stabilization that we call PEEP EIT. And finally, the last step was PEEP EIT plus 2. Next one. What do we get in this study? The PEEP level with the RDS PEEP FIO2 table was the lowest one. Using the EIT, we end up with some 3-4 centimeters of water, more of PEEP. Obviously, the last step was by definition, the highest one, because it was 2 centimeters above the black line. Next. And not surprisingly, higher the PEEP, higher the oxygenation. Next one. Here, instead, there is an important issue, in my opinion. The best compliance, you get it with the EIT PEEP selection. So this was the highest value of compliance. So the lower driving pressure, if you want. Higher than both using the NIH trial PEEP table or the PEEP EIT plus 2. Next. I do understand it's complicated, but unfortunately, in my opinion, it's important. There are two messages here. The white dot are on the x-axis, there is the recruited volume measured by EIT. And on the x-axis on the right, changes in PFO2 ratio. Not so well, depends on your point of view. There is no good correlation between changes in PF ratio and changes in recruitment. This is something not new. And we have to keep it in mind. No correlation between recruited volume and changes in PF ratio. Instead, there is a very good correlation between recruited volume and changes in compliance. Unfortunately, you have to be very precise. You have to be very precise to distinguish the changes in recruitment through changes in compliance. Going from 30 to 32 of compliance is a big difference. It's almost 10%. In clinical practice, clinicians usually are not so meticulous. That is much easier to see changes in recruited volume between 200 and 400. So the message of this slide is Recruitment is related to compliance. It is not related to changes in PF ratio. Next one. Okay, we're almost finished. On the x-axis, the PEEP value, and on the y-axis, the FiO2. The black dot are the PEEP levels selected by NIH. Obviously, they are related. PEEP and FiO2 are related by definition. According to the NIH trial, higher the FiO2, higher is the PEEP that we have to apply. This is not the same when you use EIT. You could apply high PEEP to subjects that have a very low FiO2 because they have a huge recruitment. And on the other side, you can have a low level of PEEP in patients that do, even with a high FiO2 because they do not recruit. So that's the story of personalized PEEP, personalized medicine, titration of PEEP or whatever. Next. Okay, I'll finish with usually when you do a presentation about EIT, you do many examples. This is the only one that I wanted to share with you because in this specific case, EIT helped us very much to solve a clinical issue because we could see something that usually you don't see if you don't have impedance. In this case, this is a recruitment maneuver, 20 seconds. As you can see here, in 20 seconds, you do not reach a plateau in volume, meaning you have ongoing recruitment even after 20 seconds. This is not usual, absolutely, but in this case was the case. So we decided to prolong the recruitment maneuver in this patient. Make it longer, make it twice, make it 3 times. Please do the next slide. The next slide, please. Once again. Okay, that's the end of the story. In this specific scenario, we needed very prolonged and repetitive maneuver to achieve full alveolar recruitment, but there was a lot. You could see the recruitment was almost double the tidal volume. Actually, the patient improved so much that after this maneuver went on spontaneous breathing and everything got fine. You can also see where the recruitment occurs. Not certainly on the upper part, not certainly on the lower part, or just a little bit, but mainly in the middle part of the lung. Next slide. This is the picture. There was a recruitment of about 25–30% of the lung that you could see on the upper right inside of the picture. Please, the next one. Okay. Okay. Go ahead. Well, those are my conclusions. Recruitment can be monitored by electrical impedance tomography. In the vast majority of cases, can guide PEEP setting. There are few cases in which you have unstable value of end expiratory lung volume, and this is when we do not use it. And if we set PEEP with electrical impedance tomography, we end up with different value of PEEP compared to the one that we get when we use just saturation to optimize lung recruitment. Thank you very much.
Thank you, Giuseppe, for this very comprehensive talk. So now it's time to move to Bruno Pinheiro. That the talk will be why we do not follow the mechanical ventilation guidelines.
Well, our friend from the Hospital Eugenio Espejo from Ecuador has been included in the session. Welcome, Ecuador.
To thank the organization mainly Dr. Cardinal Fernandez, for the invitation to take part in this very important event. And for the next 30 minutes, I'm going to talk about why we don't follow the mechanical ventilation guidelines. I will focus my presentation on ARDS patients and those at risk for the syndrome. The traditional protective ventilatory strategies for ARDS patients include limiting the tidal volume from 4 to 8 ml per kilo of predicted body weight and keeping the plateau pressure lower than 30 centimeters of water. One of the that gave us the basis for this recommendation is this one that was published by the ARDS network group. And this paper showed that the patients who were ventilated with 6 ml per kilo had a better survival than those that were ventilated with 12 ml per kilos. But in spite of these recommendations, some studies have shown us that sometimes we are not ventilating these patients in a protective way. For example, this one who studied patients with acute respiratory distress syndrome from 50 countries, we can see that as many as 40% of the patients received a tidal volume higher than 8 ml per kilo. When we take those patients with severe disease, we can see that around 20% of them received a plateau pressure higher, bigger than 30 centimeters of water. The point is, when we choose the mechanical ventilation, the tidal volume by the predicted body weight, we do not take in account the severity of the injury, of the lung injury. We can see in this paper, when we have a less severe lung, 6 ml per kilo can be fine. But on the right, we can see that a more severe injury, the same 6 ml per kilo can induce to hyperinflation, mainly on the ventral areas of the lungs. In this study, the tidal hyperinflation was associated to a higher level of inflammatory cytokines, and they were associated with worse outcomes. An alternative to adjust the ventilation in ARDS patients, as was shown for us by Professor Pelosi, is the driving pressure. The driving pressure considers not only the tidal volume, but also the compliance of the respiratory system. So in more injured lungs, to keep a pre-established safe level of driving pressure, in lungs with a lower compliance, we have to reduce the tidal volume. So for different patients to keep the same, with different levels of lung injury, to keep the same driving pressure, we have to choose different levels of tidal volume. The importance of the driving pressure was shown in this paper by Marcela Mato and colleagues. And in this paper, they showed on the left of the slides that when we increase the driving pressure, we have a higher risk of mortality. On the other hand, when we decrease the driving pressure, this risk reduces. Well, if we consider that we must be more restrictive in adjusting the tidal volume when we have a more severe lung, on the other hand, it would be possible to be less restrictive when we face a less injured lung, as when we face patients without the acute respiratory distress syndrome. But this concept was not shown, for instance, in this meta-analysis. In this meta-analysis, they showed that ventilating the patients without ARDS syndrome with lower tidal volumes was associated with lower mortality. But this meta-analysis was conducted with several observational studies, and some studies evaluated the post-operative patients who were kept on mechanical ventilation for a few hours. So recently, in 2018, we had this randomized clinical trial that was conducted in 6 units of the Netherlands, who evaluate the effect of a low versus intermediate tidal volumes in patients without ARDS. Patients were randomized within the first 12 hours of mechanical ventilation, and they must have not ARDS as their diagnosis. They were randomized into 2 groups: the low tidal volume, who received 4 to 6 ml per kilo, and the intermediate tidal volume, who received 10 ml per kilo. In this study, the primary outcome was resulted negative. The days out of mechanical ventilation at day 28 was the same between the 2 groups, and the mortality at ICU, hospital, 28 days and 90 days was the same, regardless the patients were ventilated with low or intermediate tidal volume. So based on this study, it's not necessary to limit the tidal volume among patients without ARDS. But we really think that, as talked by Dr. Pelosi, that maybe the more important point is not the tidal volume elected by the predicted body weight. Maybe the pressure, the driving pressure, is a better predictor to lung injury and to bad outcomes among patients with ARDS, but also without ARDS. And trying to answer our hypothesis, we conducted a prospective cohort in our unit. The inclusion criteria for our cohort was patients aged at least 18 years old, who were on mechanical ventilation for less than 24 hours, and with at least 1 risk factor for ARDS, such as pneumonia, sepsis, shock, aspiration, pancreatitis, transfusion, and others. The exclusion criteria were the diagnosis of ARDS, mechanical ventilation for less than 48 hours, and the clinical decision to withhold life-sustaining treatment within the first 7 days. We defined the protective mechanical ventilation as the driving pressure lower than 15 in at least 8% of the measurements. So the non-protective ventilation was the same level of driving pressure, but in less than 80% of the measurements. The measurements were performed twice daily for 7 days. From about 250 patients, the 148 were eligible, and we included in the cohort 116 patients. In the protective group, 78, and in the non-protective group, 38 patients. At baseline, both groups had similar features regarding age, severity scores, BMI, and the predicted body weight. Patients on non-protective mechanical ventilation had, of course, higher levels of driving pressure, but also higher levels of peak pressure and PEEP, and their compliance were worse. They had more acidosis, lower PF ratio, and higher levels of PaCO2. On the non-protective group, the patients used more frequently neuromuscular blockers. When we studied the association between driving pressure and mortality, we saw that patients who received safe protective mechanical ventilation had lower risk for hospital mortality, ICU mortality, 28 days mortality. We adjusted this variable in two models. The first one considering age, SEPS3, and vasopressure. And in model 2, the same variables and plus PF ratio, PEEP level, and compliance. And the results were the same. When we defined the protective ventilation based on tidal volume, the results were worse. We couldn't find a relationship between protective ventilation and hospital and ICU mortality, but only on 28-day mortality. We analyzed the factors that could independently be associated with the adjustment of a non-protective mechanical ventilation, trying to understand why one would choose for a more aggressive mechanical ventilation. And when we based the definition on driving pressure, the factors were pneumonia, the level of hypoxemia, the pH, and the compliance of the respiratory system. When we define the protective ventilation based on tidal volume, we also see that we use a more aggressive ventilation with patients with lower predicted body weight and those with higher levels of SAPS3, PF ratio, and bicarbonate. So, in conclusion, we think that driving pressure seems to be a better predictor to protective mechanical ventilation than tidal volume, both for ARDS patients, as has been shown by the literature, and for no RDS patients, as we tried to demonstrate in our cohort. Pneumonia, the severity of the patient expressed by SEPS3 hypoxemia, acidosis, and lower compliance, and the lower predicted body weight are associated with non-protective adjustments. And one should be more attentive for patients with these features when are adjusting the mechanical ventilation. Thanks very much for your attention.
Thank you very much, all three speakers. We are running a little bit late on this session, but maybe we have time for one question. Leopoldo, are you here? Fernando, are you here? So the Colombia team, it seems, and Argentina team, it's far from here. Okay, maybe, I raise just one question, to conclude the session, and the issue is that at the bedside, it seems that now, can you hear me? Okay, it seems that now we are using less and less the measurements based on oxygenation to titrate the PEEP. So what will be your advice, in that case, on, when to use changes in oxygenation? Shall we go first to mechanics and then oxygenation? That's my question. So Paolo, you first.
Yes, regarding your question, I'm not so sure that it's correct to say that we have not to set according to the oxygenation. So actually, I believe that we should set PEEP according to the minimal oxygenation that we can reach. We have to titrate the tidal volume according to the driving pressure. But regarding the PEEP, the evidence actually available, it seems to suggest that we should eventually titrate the PEEP level in order to avoid a further increase in driving pressure. and not according to the best driving pressure. So I think this is changing the paradigm, because we were used to set the PEEP according to the best driving pressure, while data in surgery and in patients suggest that we should eventually set PEEP or according to the oxygenation or according to the level of PEEP in order to avoid a further increase in driving pressure, not a decrease in driving pressure. So this is something which I think is different compared to some years ago. And I think also that mechanical power, as I showed you, might be a further advancement, because put together the driving pressure and the possible role of respiratory rate. And I showed you that in a large population of patients, we found a quite good association with mortality. Of course, this has to be demonstrated in a prospective randomized trial.
Thank you, Paolo. Giuseppe, EIT, electrical impedance tomography, is for all? For everybody?
You have to, the microphone, Giuseppe, the microphone.
Giuseppe, the microphone.
I send a message.
Can you hear me?
Yes, sir.
Yes.
Okay.
Giuseppe, I repeat the question.
I heard the question.
Good.
Well, beside the cost, okay, that is, it's very difficult to sell devices for diagnosis at that price. And the other point is that many believes that the EIT is only for research. Well, unfortunately, I don't have in the same time that I had when I was younger with a black hair to stay beside the patient. But if I had the EIT when I was 30 and 40, I would not have left the hospital, probably. The amount of information that you can take are amazing. I just underlined the point of the recruitment. I do believe recruitment measured by impedance tomography, beside the CT scan, is one of the best one that we have available, and is also not difficult to achieve.
Thank you.
But also in adjusting the tidal volume. And you could have a regional VP curve. And what is straight on lung compliance, total lung compliance, is not straight if you look at the regional part. Sorry for the prolonged answer.
No, that's fine. Bruno, just a short question for you. Are you worried about in people without a radius that if we use low tidal volume, so if we force that patient to breathe at 6 mL per kilogram predicted, I mean, these patients, some of them, they have hypercapnia and maybe they have some kind of distress. What's your opinion about that?
Yes, I think it must be a concern, and I'm not sure that we should keep restrict tidal volume among these patients without ARDS, and I think that they have less severe disease, so frequently they have spontaneous breathing, so it's very difficult to keep a strict control of the tidal volume. So I'm afraid in limiting the tidal volume among these patients. And I don't know how to do it, because they are on pressure support, they have efforts, so it could lead to asynchrony that could be worse than the benefit of limiting something in a non-severe disease, in a lung that could receive a higher tidal volume.
Excellent, Bruno. So it's time to close this session. I would like to thank all the people around the world that they were listening. I think has been extremely useful for everybody. So Paolo, Giuseppe, Bruno, thank you very much to be here today. It's time to move to the next session. Thank you.
El proyecto UCI Zanzíbar comenzó en agosto de 2016 gracias a la colaboración junto a la Fundación NED y muchos voluntarios, aprovechando que el gobierno de Zanzíbar había construido una nueva unidad de cuidados intensivos en el hospital La Simolla, que bueno, inicialmente estaba infrautilizada. El personal no tenía mucho conocimiento en cuidados críticos, la enfermería tampoco era la más adecuada en cuanto a conocimientos ni a personal ni en cuanto a materiales, etcétera. Y bueno, desde que empezamos nosotros iniciamos un proceso de formación del personal local de Zanzíbar. Junto a múltiples voluntarios que hemos ido yendo durante estos 2 últimos años, hemos conseguido pues grandes mejoras.
Para mí, el proyecto UCI de Zanzíbar ha supuesto un antes y un después a la hora de entender la medicina. Es curioso cómo cada vez que he ido he aprendido muchísimo más de lo que he enseñado. Yo creo que es una experiencia que no deja indiferente a nadie, es única.
Enriquecedora.
Sorprendente.
Apasionante.
Esta experiencia ha sido un desafío personal y un desafío profesional.
Evolución.
Transformación.
Agradecida.
Estimados colegas, hace un año se realizó la primera edición del Día Mundial del Pulmón, que tuvieron mucho éxito, donde más de 2.500 profesionales se incorporaron a esa sesión de que duraron 24 horas. Y luego de un año, el comité organizador, formado por los doctores Pablo Cardinal, Luis Blanch, Carmelo Dueñas, Guillermo Ortiz, Orville Baez y Manuel Gibaja, se han constituido para organizar este segundo evento que será el día 21 de noviembre. Quiero agradecerle al comité organizador y a todos los oradores que van a estar presentes el día 21 de noviembre y asimismo destacar lo inclusivo que han sido para poder realizar este evento. Asimismo, quiero agradecer a las empresas que han sponsoreado el Día Mundial del Pulmón. Gracias por estar presente y éxitos en la nueva edición.
The European Respiratory Society, I'd like to wish you every success with your meeting. Respiratory disease is something that affects millions of people worldwide, and taking care of these patients, especially in circumstances of emergency and critical care, is extremely important. There are many patients, there's a lot of suffering, we should be able to prevent it and alleviate it. The European Society is the largest respiratory society. We're European-based, but we have members in 162 countries, over 32,000 members, and we all try to do our best for our patients. So we promote science, we promote education for our members, but also education and information for our patients, and advocacy. So we work with policymakers to make sure that everything, easy access to care, early diagnosis, and best care is available for our patients. With this in mind, I'd like to wish you every success to your meeting. Everything we do in respiratory medicine is important and it has an effect on patients. And I would also like to invite you to our meeting in Paris this coming September. Every success to your meeting.